Welcome to Science Force, where science comes alive. Welcome everyone to today's explainer. Whether you're a curious learner trying to understand your own body or a medical student gearing up for clinical rotations, you are in the perfect place. Today, we're decoding the incredible mechanics of our joints, those brilliant biological shock absorbers that carry us through life, and exactly what happens when they start breaking down. Okay, let's dive into this. So, let's establish a really clear baseline here. Osteoarthritis, or OA, is what we often call a wear and tear joint disease. It's a chronic condition where the articular cartilage, that beautiful protective cushioning at the ends of our bones, just gradually wears away over time. Now, it's absolutely crucial for our med students to separate this from other forms of arthritis. Unlike rheumatoid arthritis, which is primarily a systemic autoimmune inflammatory issue, OA is fundamentally a mechanical problem. It's a degeneration issue. Though, as you'll see a bit later, inflammation definitely crashes the party eventually. Here's our roadmap for today's explainer: the baseline, the breakdown, the catalysts, the red flags, and finally, the fix. Part 1. The baseline. Before we look at the destruction, we need to understand the harmony of a healthy joint. Look at the striking contrast. On one hand, you have a perfectly healthy joint. Think of the articular cartilage here as a smooth, rubbery, incredibly slippery shock absorber. It's constantly bathed in synovial fluid, which is pumped out by the synovial membrane, giving it rich nutrients and brilliant lubrication. This literally lets your bones glide past each other without a hitch. But then, look at the osteoarthritic joint. That gorgeous smooth surface? It's damaged. It's totally roughened up. The vital shock absorber is practically gone, which means bone is rubbing directly against bone. Imagine that. It creates immense friction and inevitably some serious pain. Part 2. The breakdown. Let's zoom in microscopically and look at the 5 stages of pathophysiology. For the life science students tuning in, this destruction doesn't happen overnight. It follows 5 very methodical stages. Stage 1. Injury. Cartilage injury. The primary cells maintaining our cartilage, the chondrocytes, get damaged from stress or simply aging. The cartilage loses its delicate water balance and gets soft. Stage 2. Degeneration. That smooth surface actually develops deep cracks and fissures. Stage 3. Joint space narrowing. As the cartilage literally wears away into nothing, the bones inch closer and closer together. This is exactly what we spot on an X-ray. Stage 4. Bone remodeling. The body frantically tries to fix itself, but well, it does a pretty terrible job. It creates these abnormal bony growths called osteophytes or bone spurs. Plus, the bone right underneath the cartilage hardens up, a process we call subchondral sclerosis. Stage 5. Inflammation. Inflammatory chemicals, specifically interleukin-1 and matrix metalloproteinases, which are basically enzymes that chew up tissue, flood the joint, and just accelerate the whole breakdown. Part 3. The catalysts. So what actually triggers this whole cascade? Well, it's a fascinating blend of the inevitable and the preventable. Primary osteoarthritis often boils down to aging and genetics. You know, our internal repair mechanisms just get a bit lazy after the age of 50. We also see a spike in postmenopausal women due to dropping estrogen levels. But look at the secondary factors: repetitive joint use, like we see in athletes or factory workers, and absolutely crucially, obesity. Think about this. Every single step you take places several times your actual body weight right onto your knees. The sheer mechanical force working against our joints every single day is truly staggering. Part 4. The red flags. Let's talk about the symptoms and the common sites where this strikes. The absolute hallmark symptom here is joint pain, but it's a very specific flavor of pain. It distinctly gets worse when you're active and actually feels a bit better when you rest. Patients also wake up with morning stiffness, but here's the key detail. It usually lasts for less than 30 minutes. That's a massive clue that helps us differentiate it from rheumatoid arthritis. You'll also notice reduced mobility, and here's something called crepitus. Crepitus is that unmistakable, awful, grinding, crackling sensation when the joint moves. That's literally the sound of those roughened, damaged cartilage surfaces scraping against one another. And this brilliantly illustrates exactly where osteoarthritis strikes the hardest. In the knee, you get that crackling crepitus, and in advanced stages, even a bow-legged deformity. In the hip, the pain often radiates straight to the groin or buttock, leaving patients with a pronounced limp. Now, medical students pay very close attention to the hands. OA produces very specific hard bony bumps down at the distal joints, the ones closest to your fingernails. We call them Heberden's nodes. In the proximal joints or the middle knuckles, they're Bouchard's nodes. And finally, if it hits the spine, those rogue bone spurs can literally pinch the nerves exiting your spinal cord, causing radiating numbness and tingling. Part 5. The fix. Let's move on to clinical management and prevention. So how do doctors diagnose and manage this? Well, diagnosis comes down to a solid clinical exam and an X-ray to spot that classic joint space narrowing and subchondral sclerosis we talked about. But the absolute cornerstone of managing this chronic condition might actually surprise you. It is not resting in bed. It's exercise therapy. Getting out there and walking, swimming, cycling, or doing yoga is absolutely vital. Why? Because when you strengthen the muscles surrounding the joint, they provide better support. They essentially take the mechanical load off that damaged cartilage. Physical therapy is a literal game changer for improving mobility and stability here. 5 to 10%. That's the magic number. If a patient happens to be overweight, achieving just 5 to 10% drop in their total body weight can dramatically decrease the mechanical stress on their knees and hips. To put that in perspective, the relief in daily pain and function from just this modest weight loss is incredibly significant. It is truly one of the most empowering preventative steps anyone can take for their joint health. But of course, when lifestyle changes just stand cutting it, we bring out the pharmacological arsenal. We usually start simple with analgesics like paracetamol or NSAIDs like ibuprofen to tackle the pain and that mild inflammation. If the symptoms are stubborn, doctors might use injections, corticosteroids for a rapid cool-down of inflammation, or hyaluronic acid to basically artificially lubricate the joint. And finally, for the most severe disabling cases where the cartilage is just totally gone, we look to surgical management. Things like a total knee or hip replacement, they literally swap out the damaged biological surfaces for sleek artificial components to give patients their quality of life back. Which brings us to a very important final thought. Your joints carry you through every single step, every leap, and every beautiful moment of your life. So based on what we've explored today, are you carrying them towards an inevitable breakdown, or are you actively steering them towards repair and longevity? It's a fascinating question to reflect on, isn't it? Thank you so much for joining me for this explainer. And as always, keep learning. Thank you for watching Science Force.